Great, good afternoon, everybody. This is Dana Harganani, Chief Medical Officer for the Oregon Health Authority, and this is our third week of providing healthcare provider webinar informational updates related to COVID-19. Welcome back. Today, I am joined by three of my colleagues, Dr. Dean Seidlinger, who is the Oregon State Public Health Officer and State Epidemiologist, Dr. Tom Jean, who is the Deputy State Public Health Officer and Deputy Epidemiologist, as well as Dr. Ariel Smits, who is the Medical Director for Oregon's Health Evidence Review Commission. All of us are tasked with supporting our state effort on COVID-19. Looking at our topics today, once again, we have collected questions that you provided during last week's webinar and through our email address, which I'll show again at the end of this webinar. And the majority of the information we're bringing back to you today are on answering those questions or providing you with new information. The topics we'll cover today, just a brief update on COVID-19. We'll spend some new time with Dr. Seidlinger sharing some projected COVID-19 epidemic trends and what those mean for Oregon. And then we'll go into some more detailed information and Q&A responses regarding testing general COVID-19 questions, clinical care guidance and triaging, telehealth coverage, personal protective equipment, healthcare workforce, and then we'll close out with additional links for you to get your ongoing resources moving forward. So just briefly, I actually need to clarify this slide is as of March 30th. Yesterday, we were waiting for the new data today, so there is an error on this slide. And the new data should be available shortly. We will update this appropriately before we post our slides. But as of yesterday, March 30th, we had 606 known positive COVID-19 cases, 16 deaths in our state, and over 12,000 negative tests. And as you'll be hearing briefly as Dr. Seidlinger walks through the trends, we know that community transmission is broad and these specific test results do not reflect the full impact of COVID-19 in our state. So I will invite Dr. Seidlinger to speak.
Thank you, Dr. Harganani. So again, similar to Dana's data, this is the epidemiological curve from yesterday. It shows the cases across Oregon since they were first detected, plotted by date of onset, with blue indicating patients who are hospitalized at any point during their illness, orange cases that were not hospitalized during their illness, and gray are cases that the data is not available, but as the investigation continues, we hopefully will be able to fill that in. The points to the right of the graph are days that we continue to receive case information, so those numbers are likely to change. So it's not that we're seeing a decrease in cases, it's just that the case reports lag. We have used this data on the daily case counts and some information about the cases to inform modeling to try and project where Oregon's going to be in the coming weeks and months. We've had modeling done on several different levels internally within the Oregon Health Authority in concert with Oregon Health and Science University, and are also providing data to researchers and modelers across healthcare systems so that as they do projections, they have the latest Oregon data on which to base their projections. The researchers communicate regularly and update their models. I'll look at the next slide and we'll talk about the Institute for Disease Modeling data. This is modeling that they released last week for the state of Oregon. The Institute for Disease Modeling is in Bellevue, Washington. They're an internationally known group that does a lot of communicable disease modeling. They worked to do similar models for King County and for the broader state of Washington, and have been a great partner with us here at the Oregon Health Authority in modeling for the state of Oregon. These models were released last week around the time that Governor Kate Brown's latest executive order on stay home, save lives went into effect, that shut down additional businesses that were considered non-essential and encouraged more working from home. The blue line shows if all of the models were released last weekend where our cases would be trending by early May. The orange line showed moderate interventions that were in place through last weekend, and the green line did show, tried to model the aggressive interventions that were implemented last week in the state of Oregon with approximately 90% compliance. We continue to provide daily case counts to our partners at the Institute for Disease Modeling and are working on an update to this model. What we do know is that with the additional case information provided, including more robust information on hospitalizations, that we expect our new modeling results that will come out this week to show a slightly higher estimated number of cases. These models show the estimated cases in Oregon, not just the tested cases, and we anticipate that number will be increased on the graph that comes out this week. But what we also anticipate is that the model will show that the aggressive actions we have in place have started to make a difference, that the sacrifices Oregonians are making to try and flatten the curve, which is a term that we no longer have to define, that a lot of people understand, to flatten the curve so that we don't overwhelm the health system, are working, and that we likely have about a 50% decrease in transmission compared to baseline if we hadn't implemented some social distancing measures. That doesn't mean that our job is over as Oregonians, that the need to stay at home and prevent the spread of cases will continue to be needed. And this also means that this would keep cases under the projected hospital beds that are available, but that also is built on the fact that we have adequate personal protective equipment to protect our pre-hospital providers, our healthcare providers, and that they're able to stay healthy and come to work to care for Oregonians. So I think our modeling will continue to work to update it weekly. We will continue to use it in providing information out to the public and to our decision makers, but we also continue to plan for building additional capacity within our healthcare system, knowing that models are not predictive, but really are a tool to help in planning. So we will continue to work on what could be worst case scenarios to make sure that we're ready to provide high quality, robust healthcare to Oregonians as they need it. This slide, again from last week, that we anticipate some updates. We are likely tracking around the orange line on this slide. We anticipate that this week those numbers will be slightly increased, but all of those lines track below existing capacity for adult acute care beds and ICU beds across the state of Oregon. But we know that with some of the uncertainty in the model, those shaded areas, we could be significantly higher, and particularly as if people's compliance with staying at home orders wane. So we continue to work to provide messages to the public about the need to stay at home, the difference that people are making, and the incredible sacrifices that they're making are helping us in the short term. And while we identify a way to come out of this shelter in place or stay home, save lives model. Next slide.
Great, thank you. Did you?
Yep.
Thank you, Dr. Seidlinger. So we will be sharing again our website at the end of the slideshow today, and this modeling will continue to be updated as new numbers come in and projections to the website so that you can track that information and get further details on the modeling. Great, now we're going to move over to some responsiveness to your questions that came through. And first, Dr. Smith is going to respond to some of the general COVID questions that we received.
Good afternoon. So this is really just answers to things that have come up in the past week, and continue to send us questions. We're happy to answer them. One was about what % of patients are asymptomatic. And based on studies, mainly in the Princess cruise ship passengers and Japanese citizens who are repatriated from Wuhan, somewhere around 18 to 33% of COVID test positive patients remained asymptomatic. And another study in China found about 13% of children were test positive and never symptomatic. A question was raised about the rate of co-infection of COVID-19 with other viruses. It's pretty consistent across studies that about 20% of patients with COVID also test positive for influenza A or B, RSV, rhinovirus, adenovirus, and other respiratory, upper respiratory viruses. There was a question about predictions of which patients will get a cytokine storm. That is an active area of investigation and no answers to that. There was a question about in the United States, what % of positive cases are serious versus mild. According to the latest figures from the CDC, about 20 to 31% of US COVID positive patients require hospitalization, and 5 to 11% of those require ICU admission, and 1.8 to 3.4% have died. This is likely an overestimate of the severity of the disease due to our low level of testing and bias toward testing the most ill patients. There was a question about using commercial hand dryers that use air to dry hands. And interestingly, there was a 2012 meta-analysis that found that air dryers significantly increased the spread of bacteria and viruses compared to paper towels. And out of abundance of caution, healthcare settings should probably use paper towels. There was a question about whether acupuncture can result in aerosolization of the virus, and the answer, as far as we know, is no. There was questions about quarantine recommendations for COVID positive patients or symptomatic patients that live in communal shelter settings. On the OHA website is a pretty comprehensive guidance for that. In a nutshell, symptomatic persons should wear a mask if possible. If not possible, caregivers should wear a mask. They should stay 6 feet away from other individuals, should not share bedding, etc., with other individuals. There was a question about how long or how many people an asymptomatic individual can infect. According to the CDC, asymptomatic individuals have a low risk of shedding virus. There's only been case reports of spread of the virus from an asymptomatic person. There's questions about how to safely deliver boxed food or medications, or how to safely unbox them. There is some evidence that virus can live on surfaces. The recommendation there is to always wash your hands after opening any containers or anything that's delivered to you. And then there was a question about whether anosmia, a lack of sense of smell, is an early indicator of COVID-19 infection. The Oxford Center for Evidence-Based Medicine reviewed this topic and found insufficient evidence that it was a clinical feature of COVID-19.
Great. Thank you, Ariel. And we're going to move on, and Dr. Tom Jean is going to speak to us about some updates on testing guidance and respond to some questions that came through.
Yeah, thanks. So first, I'd like to look at these slides here. We've only had minor updates to our guidance since last week for testing, mostly just for clarification. This is our current recommendation for the suggested groups of people who should be tested at clinical laboratories. And again, this is just a recommendation, just guidance. It's certainly up to the treating provider to decide. So for people who have a compatible illness, fever, cough, or dyspnea, includes these high-risk groups, including healthcare workers and first responders, people over age 60, people with underlying conditions, and pregnant women. We still have the line there about people who have known contact with a confirmed case or suspect case, or who had travel. That's still in there, but it's expected to be less of a concern in our current setting of widespread community transmission. And then the next slide is just showing our state lab, the state public health lab criteria for testing. So we are prioritizing and focusing on these two groups in the state lab. And so these are required for tests to be approved. Hospitalized patients with viral lower respiratory infection and flu testing ordered. We have changed this from a flu test negative requirement. We would just like a flu test ordered while it's still flu season. And that's because of concerns of co-infection. And then symptomatic people who are in a high-risk congregate setting, like a long-term care facility, healthcare facility, corrections, etc. So now I'll go through some of the Q&A for testing. And we've got about 10 questions here. So the first question was, do we have a test for immunity? So we have numerous companies that are starting to offer more and more tests, including serology tests, which would be blood tests that would look for antibodies. Unfortunately, none of those are FDA approved under the emergency use authorization. We're hoping the FDA approves some very soon. Many of these are actually rapid serology tests that would look for both IgM and IgG antibodies in blood. and the IgG would be the type of antibody that would confer long-lasting immunity. In terms of the question of immunity to the SARS-CoV-2 virus, we still really don't know if there will be long-lasting immunity after somebody recovers from a COVID-19 infection. Looking at some of the other coronaviruses and research that was done on them, the SARS infection, the original SARS-CoV-1 virus, led to long-term immunity in some studies of 8 to 10 or more years. Whereas the MERS virus led to immunity only lasting 1 to 2 years. So we'll see which of those is closer to the SARS, the current COVID scenario. And then there was a study in macaques with the current coronavirus, the new coronavirus, suggesting that once infected, they produce neutralizing antibodies and resist further infection. But of course, we don't know any long-term data on the duration of those antibodies. Okay, so I hope that answers some questions out there about immunity. Next question was about oropharyngeal swabs. Is performing an OP swab for rapid strep testing or strep culture considered an aerosol generating procedure, and what PPE is required? So no, that is not considered an aerosol generating procedure, so we would recommend contact and droplet precautions with eye protection. That would also apply to NP swabs or nasal washes. Next question is, when is the best time in regards to symptom onset to collect a COVID swab to ensure we don't get a false negative early in infection? So again, we don't have a definitive answer to that yet. And this is really a question of both viral load and the specimen collection site, because we know that the virus can hang out in both the upper respiratory tract as well as the lower respiratory tract. Some of the early case studies have showed some significant variability. Some showed a high viral load early in symptoms, even before a cough begins in some cases. And then I did see a recent pre-proof study from China looking at 51 hospitalized patients with COVID-19, and the majority of those patients had their lowest PCR cycle threshold value, in other words, the highest viral load on the first day of hospitalization. Next question was, shouldn't healthcare providers be tested for COVID-19 even though they have no symptoms prior to providing patient care? So that is not our recommendation given current testing capacity. A negative test, we have to remember, it's only a snapshot of a point in time, and it's not a guarantee that a provider isn't already infected but it's still in the incubation period. Or that the provider won't be exposed the day after the test is collected. So at this point, we're not recommending asymptomatic testing, including of healthcare providers. Next question was about drive-through testing requiring a referral from a provider. Can you discuss what this involves on our end so we can be doing everything we can as providers to attempt to get symptomatic patients tested? So I know that Providence, OHSU, and Kaiser are doing drive-through testing currently, and that in those cases, the prescription for testing would need to come from a provider affiliated with that health system. So I think you just would have to check with your facility, and most of the sites also require an appointment for the patient. I believe some sites are also testing symptomatic first responders. So I hope that answers that question. Next question was about urgent care sites. Will urgent care sites get supplies to test soon? We need supplies that we can't order. And yeah, unfortunately, testing supplies are the main limiting factor at labs across the state and across the country. A lot of our major labs are still concerned about having enough reagents and collection kits. So I don't know if I have a good answer for urgent care sites who aren't able to get hands-on supplies right now. The next question was, can the test be ordered to be done at the lab? It was my understanding that the provider has to do the collection, i.e. swab. Yeah, so testing requires a provider for collection. We're not aware of any labs that are doing specimen collection for COVID-19. CDC recently changed their guidance last week regarding the type of specimen, however. So now anterior nasal swabs and mid-turbinate swabs are acceptable. So that may open up the possibility for self-collection in the near future, but we'll just have to see. I haven't seen the data for that yet. Next question, why does flu screening matter when there are decent rates of co-infection? If the rapid flu is positive, shouldn't we still test for COVID-19? And as I mentioned before, our testing guidance changed last week to reflect that concern, but we do recommend flu tests be ordered as long as flu is circulating, but we no longer require a negative flu for COVID-19 testing. Any plans for large-scale drive-through testing done by the state? I'm not aware of current plans, but that's something that's on the radar as test availability continues to increase. That's something we might consider. Any plans to have another testing site available in Southern Oregon besides the one located in Southern Medford? So I know that hospitals around the state, including Asante Road Regional Medical Center, are working to get rapid automated PCR testing in-house using the Cepheid or BioFire machines. That may be still several weeks away in some cases, but it's going to really help our testing capacity all over the state to get those up and running. There's a question about Providence, the question stating that Providence is able to get PCR results back in 5 to 7 hours. What is the status of others? I think these larger systems in the metro area that are doing their in-house testing are getting the results back within a day, but I can't speak to the number of hours. And the last question, how many tests can the state accommodate overall at this time? So as of a few days ago, Oregon's total state testing capacity, including the state lab and including the health systems, was up to 1,600 COVID-19 tests daily, assuming adequate supply. And we expect that to increase in coming weeks, as I mentioned.
Great, thank you, Tom. So we are going to now go through some updated guidance that has come out regarding clinical care, and then also walk through some questions that you've sent to us. So first, I'm going to have Dr. Jean start again here and provide some information about this guidance.
Yeah, so on March 27th, we made some significant changes to our clinical care and healthcare infection prevention guidance, and the highlights are here. So first, we have new criteria for discontinuation of transmission-based infection prevention precautions, and it prioritizes a test-based strategy for patients that require continued hospitalization or will be transferred to a long-term care setting. So they would need 2 negative tests 24 hours apart in that case. For everybody else, it's 72 hours after resolution of fever and cough. There's also updates to recommendations on work exclusion and monitoring, which allows asymptomatic healthcare workers who've had an exposure to a COVID-19 patient to continue to work with strict self-monitoring for symptoms. So that would be twice daily symptom and temperature checks. And then lastly here, return to work considerations. We've simplified this to it's a minimum of 72 hours post-resolution of fever and cough, and we have some best practices and considerations for crisis care scenarios. So I encourage you all to have a look at the updated guidance. It's hopefully very useful.
Great. Ariel, can you walk us through some answers to the questions we received?
Sure. So these were your questions from the past week that had to deal with clinical questions. The first was, what recommendations should triage nurses have to assess shortness of breath? And that nurses at clinics are requesting assistance. So the Oxford Evidence-Based Medicine Group has actually looked at this. There is no validated tool that has met evidenced kind of cutoffs. Based on expert opinion, the recommendation is to have a patient describe their breathing in their own words, use kind of open-ended questions like, how is your breathing? And then listen to how they're actually sounding. And then use a symptom checker, like, are you so breathless you're unable to speak more than a few words? Do you breathing harder or faster than usual when doing nothing at all? Are you so ill you've stopped doing all your usual daily activities? Types of that, questions of those nature. And then focus on change. Has there been a change in your breathing? Are you more breathless than yesterday, etc. And then also take into account any physical signs such as audible wheezing or verbal report of blueness of the lips, etc. The next question was a question about whether asthma patients should continue or stop their daily inhaled steroids. It is actually advised that they continue their daily inhaled steroids. There is good evidence that stopping inhaled steroids doubles the risk of an asthma exacerbation in the next 6 months. Overall, we don't know what the effect of the inhaled steroids would be on COVID. On other URI viruses, there's evidence in some cases that it increases the risk of a URI, and in other cases, certain COVID viruses are actually inhibited by corticosteroids. So it could have a protective effect, deleterious effect, or unknown. So please have your patients continue their daily inhaled steroids. What about nebulizers? How should you continue to use those? How should you protect family members from getting ill? The recommendation is to use inhalers if at all possible. Evidence shows inhalers are just as effective as nebulizers. For those patients who are unable to use inhalers, do not stop prescribed nebulizers without consulting with a healthcare provider, and try to minimize the number of caregivers involved in the nebulizer therapy. For example, have just one family member assist if possible. And then there was a bunch of questions about the governor's order to delay routine care. The recommendation of OHA is that you can continue to provide care via telemedicine, telephone, video conference, etc. If the patient's health concerns or symptoms require immediate evaluation by a physical exam or lab testing, please go ahead and have that patient be seen and have the lab test, etc. But try to schedule ill visits for later in the day. If a patient's concern or medical issues can safely be addressed in 6 weeks or longer, please delay appointments, tests, etc. Specifically, we had some questions about gynecology procedures. Routine contraceptive procedures, such as putting in an IUD, is considered to be something that can protect someone's long-term physical or mental well-being, and is covered as something that should be continued. Similarly, procedures that might affect cancer outcomes, such as endometrial biopsies, colposcopies, etc., should be continued. There was a question about dermatology appointments. To preserve PPE, do as many visits as you can via telephone or video. If a lesion is concerning for skin cancer, a biopsy can be done if you think it will reduce the risk of cancer progression. There's a question about whether Oregon is considering reducing standards for pre-employment background checks for home health and hospice workers, and there has been no such consideration to date.
Great, thank you. So we are now going to move on and walk through a number of slides relating to updates on telehealth. Some of this is a review from before, and some of it is new information. Last Tuesday, we referenced the new guidance that was forthcoming from the Oregon Health Authority and the Department of Consumer and Business Services. That guidance has since been updated and posted. At the bottom of the slide, you can see where you can find the full guidance. Again, this video of this webinar will be posted to our website too, so you can find all this information. I've pulled out a couple key points from the telehealth guidance that is directed at both our commercial plans operating in our state, as well as our Medicaid health plans or coordinated care organizations. So the guidance from OHA and DCBS state that health plans shall cover telehealth services delivered by in-network providers to replace in-person visits whenever possible and medically or clinically appropriate. The guidance also says that health plans shall examine reimbursement rates for telehealth services to ensure they are adequate to enable providers to increase capacity to serve patients with appropriate telehealth delivery methods. Health plans shall ensure cost-sharing requirements for services delivered via telehealth are no greater than if the service was delivered through in-person settings. And health plans shall clearly communicate, such as prominently posting information on their website, to their members and provider networks about options to receive healthcare services via the appropriate telehealth delivery modes, as well as how to bill for such services. While this guidance is going to be overarching, it definitely will give you a sense of what direction has been given to commercial and Medicaid plans in our state. And again, you can find the full set of guidance in the link that we have shown here. It is posted both on the OHA and the DCBS websites. Much of this guidance that was directed by OHA is underway for the Oregon Health Plan. On this slide, you can see that we have some links to the coverage that is outlined under our prioritized list of health services that went into effect on March 13th. And also specific guidance and recommendations around an intent of how telephonic services should be covered during an outbreak or epidemic. So this is just more detailed about the intent of the coverage for telehealth services during COVID-19 outbreak. Moving forward, again, these next several slides go into further detail about the Oregon Health Plan coverage of telehealth and phone visits. There have been some updates here that I want to outline, but not go through these all in as great detail. So during our last webinar, last Tuesday, we shared that there are about, 6 different types of telehealth services that are now covered under the Oregon Health Plan. The first type, as you see here, is telehealth synchronous video and audio. So these are visits with a provider in which the patient and provider interact by audio and video in real time. Ideally, this is through a HIPAA compliant system. However, you can see here under the first note that some of those compliance or regulations have been lifted during the COVID-19 epidemic by CMS, so that you are able to utilize other tools as acceptable during this particular epidemic to ensure that is accessible to providers and clinicians, providers and patients. There are extensive lists of codes that you can see through some of the reference materials we'll have coming forward. The use of telehealth synchronous video and audio are considered for use in inpatient settings, outpatient, and for both new and established patients. The next type of telehealth visit that is covered are considered e-visits. These are asynchronous electronic visits such as through Epic MyChart as an example, or other platform for patient portals. You can see here some codes. While the codes indicate established patients only, as you see here under footnote 2, the Oregon Health Plan fee-for-service is not going to audit for compliance with established patient requirements for these services, and our coordinated care organizations have been asked to allow telephone services for new patients during this COVID-19 outbreak to make sure, again, that people are accessing the care that they need safely through telehealth visits where medically appropriate, whether they're a new patient or an established patient. The third footnote here is also important to remember. For these e-visits, providers can broadly make their patients aware of the service, but the specific e-visit request of service must be elicited by the patient themselves. A couple other key points, telephone visits as well. These are just telephone. There's no audio or video synchronizing happening. You see here some codes. Again, the same thing will hold true where typically these are indicated for established patients only. We are loosening that requirement, and CCOs have been asked to allow telephone services for new patients during this period specifically of COVID-19 outbreak.
Dr. Harganani,
yes,
just to
please do.
That the telephone-only visits are now open for new patients as well. That's new guidance from CMS.
Great, thanks. And if you're looking at the slide, it's not only OHA, it's ICCMS. So the footnote 2 again is saying this is really for new patients as well as established. We did not update that in the use on the far right column. Sorry for that confusion. Several of these you'll see linked in data 2 are now during COVID-19 available for new patients. We won't go into further detail of the rest. We did cover some of these during our last webinar, but just wanted to make sure you were aware of the flexibility that has been loosened around allowing these services where indicated on this graph to be available to new patients during this period of time. And then finally, we also have some coverage under OHP for preventive medicine services when they're appropriate and possible without physical exams. So these would include specific codes such as for immunizations that could be billed separately and delivered, for example, through a drive-through setting where you're trying to reduce the physical interaction and potential of transmission of COVID-19. So another tool as you're developing your approaches to delivering clinical care at this time through telehealth services or this preventive medicine type of coding that we just showed here. Also, what we wanted to share, another set of recent occurrences and updates, is that the Oregon Health Authority is directing our coordinated care organizations under a temporary rule filing on telemedicine payment parity requirements to reimburse contracted physical and behavioral health providers for covered services provided to Oregon Health Plan members by means of telemedicine, including telephone, as at the same rate paid when such services are provided in person. Again, this is trying to make the reimbursement support this service currently during this COVID-19 outbreak, such that this is a meaningful means for providers to deliver healthcare during this time. The second bullet is not as, we're directing that the payments for telehealth services be on parity with services that are covered by that are covered for in-person services. It's not specifically related to our fee-for-service rate. That is probably more detailed than necessary on this slide, but I think the first bullet point is the most important. Coordinated care organizations will continue to reimburse non-contracted providers for telemedicine service at the rates agreed to between the provider or at the OHP fee-for-service rate, whichever is greater. Again, a lot of detail, but just trying to share that we are really focused on increasing our reimbursement rate of telemedicine service for Oregon Health Plan members during this period to make sure that it is accessible and doable for our providers across the state. Just a couple more points. Telemedicine services must be delivered consistent with all relevant Oregon administrative rules, including requirements related to language access, interpreter, and translation services. That is really important as we continue to ensure equitable access to important healthcare services during this period. I'm going to move on from here. This is just some ongoing resources for you to keep up to date on the situation. It continues to evolve as it relates to telehealth guidance and billing and payment information. You can see here we have several sites that we'd recommend for you to visit. The Oregon Health Plan Partners COVID-19 page here includes the information we just shared on OHP telehealth coverage. It also includes guidance on teledentistry, more specifics for FQHCs, PA requests, presumptive eligibility, and behavioral health. So much more broad than telehealth, and we encourage you to visit it if you provide services to OHP members. And we'll continually be updating. We have lots of new information as of yesterday, where CMS is providing significantly greater flexibility in the way we can deliver services and pay for services. And so this is a fluid area that we will continue to update readily and bring back some highlights to you at our next webinar. There's also information here about HIPAA enforcement from HHS, federal HHS. This Division of Financial Regulation within the Department of Consumer and Business Services. Again, more information about state regulated insurance as it relates to coverage for coronavirus related services. And then finally, a Medicare fact sheet, which would be worthwhile to take a look at. With that, we are going to move from telehealth and we are going to talk about some personal protective equipment updates, and I'm going to pass it to Dr. Jean just briefly.
Yeah, so the recent changes to that healthcare infection prevention guidance document that I mentioned also included some recommendations on extended use of mask and face shield for cohort care of patients with COVID-19. So that would be patients on one unit. And so there's just a little bit in there about this that refers to some CDC guidance, but we also appreciate that more granular guidance would be helpful. And we are very close to releasing some interim guidance on the use of PPE by healthcare personnel in resource-constrained settings. with kind of a playbook for responding to a challenging pandemic situation. And so we have recommendations that will be arranged in 4 tiers, with each successive tier outlining approaches to consider under increasingly resource-constrained situations. So stay tuned for that. That will be posted on our website this week, and should be helpful for a lot of the concerns that providers and health systems have regarding PPE supply and best practices.
Great, thanks, Tom. A couple slides that should be reviewed from last week. As you know, Governor Brown's executive order, as referenced here, required that a procedure is subject to cancellation if it is elective or non-urgent, and the procedure requires the use of PPE. Again, one of the primary reasons for this executive order was to maintain the supplies of PPE that we need for the urgent response, specifically to COVID-19. Dr. Smith already responded to a few questions that related to this type of like what fits and what doesn't fit as an elective procedure. We just wanted to share with you, we do have a guidance posted on our website. Here are a couple of the high-level specifics about this, this executive order. So again, a procedure is exempt from the cancellation requirement if delay would put the patient at risk of irreversible harm. Risks of irreversible harm include, but are not limited to, threat to patient's life, threat of irreversible harm to the patient's physical or mental health, threat of permanent dysfunction of an extremity or organ, risk of cancer metastasis or progression of staging, and rapidly worsening condition risk. So, such as the procedure is very time sensitive. Also, if you as a healthcare provider believe that a patient will suffer irreversible harm if a recommended procedure is delayed or foregone, then you should provide that care using as little PPE as is safe and consistent with applicable infection control guidelines and laws. Again, we recommend for you, if you have questions about this, to look at the guidance that we have posted on our website, and the link is provided here. We won't go into this in general. Again, we've provided this update, but we have over the last couple of weeks gotten lots of questions about aerosol generating procedures. I'm going to have Dr. Jean just review for us the recommended PPE use when you're performing one of these procedures.
Yes, so it would be standard contact and airborne precautions with eye protection. So gown, gloves, N95 or better, respirator, and goggles or face shield. And ideally, these would be done in a negative pressure room.
Yeah. And I think, again, Dr. Smith's answered some questions, for example, about a nebulizer. If you do have a patient who needs to use a nebulizer, you need to, if you're in an office setting, you want to make sure you have the appropriate PPE, as just mentioned. If you're in a home setting, you want to limit the number of people involved in that care delivery to reduce that risk of potential transmission. Thank you. We realized, my fault, I missed on including a link here. We have already, I think, answered a few of the questions that came through on PPE already. We know this continues to be a very significant area of concern. Dr. Jean mentioned that we will have an upcoming guidance that I think will be really helpful during this resource-constrained period of time. We are aware there are many entities who are collecting PPE as we speak. So certainly hospitals and health systems are collecting PPE or collecting it across our health system where it's not needed for use of COVID-19 response. We know that there is collections happening at the county level, and our state has also been collecting a lot of PPE through our centralized collection, our emergency coordination center. That could be from various federal stockpiles or other donations coming in. How that PPE is being distributed out is based on the recommended distribution criteria that our multiple health system partner and county partners have helped to inform that guidance. We wanted to post it here, and we're going to make sure to post it before we put the slides up on the web, so you can see that criteria and how that is being utilized as we distribute out and respond to requests for PPE. Again, this is specific to our state stockpiles in collections that are coming in at a state level. We continually revisit those distribution criteria to make sure that they're making sense for the time period that we're in, both regarding resource constraints and where we are with COVID-19 epidemic. If you're hearing interest about people donating materials, we've had lots of people coming forth. If there's interest to be able to find a location for donating those at the state level, this is the website that people can get more information and guidance about donating materials. All right, we are getting close. We're going to close out with a response to the questions that came in regarding healthcare workforce, and I'm going to pass it back to Dr. Smith.
So there were just a couple questions about healthcare workforce. There was a question about doctors who are currently not in the workforce for any reason, recently retired between jobs, etc. What can we do to help? The Oregon Medical Board has changed rules to expedite relicensing of recently retired providers. To qualify, a licensee must have been in active clinical practice within the past 3 years and must have been in good standing at the time the Oregon license became inactive, lapsed, or retired. There is a link on the OHA website, or you can go directly to the Oregon Medical Board if you're interested in reactivating your license. Additionally, the State Emergency Registry of Volunteers in Oregon, which is SERV-OR, is calling for licensed healthcare providers to sign up, train, and deploy in support of the state's COVID pandemic response. There's, again, a link on the OHA website, or you can just Google SERV-OR and get to the correct place to sign up for that. And please do. Anyone who can help would be greatly appreciated. And then the other question was whether there has been any discussion about suspending civil liability for healthcare professionals who are caring for our state population under the state of emergency. We are aware that there has been some federal discussion about possible civil liability issues, but nothing has been done to our knowledge at the state level.
I do want to add for healthcare providers who end up providing support as a volunteer through SERV-OR, through that tool, that work would be accompanied by medical liability coverage as well as workman's comp coverage. So just so you know, if you are, that more information is available on SERV-OR, but those items are covered if you're volunteering as a healthcare workforce member. Great, so just closing out, we wanted to reorient you back to our website specific for healthcare providers, healthoregon.org/coronavirus-HCP. Without the HCP, you go to our overall coronavirus website, which has lots of in-depth information, updates on numbers, etc. But the HCP specific edition takes you to the information specific for healthcare providers. We've referenced many guidance and guidelines that you can find on that website. I encourage you to keep taking a look. That's where things will be posted as updated. We apologize that we can't do real-time Q&A during these webinars. We are so pleased to be able to respond to the need for continual information. We've had upwards of 800 to 1,000 members of our healthcare workforce across the state join us on these webinars. Due to the way we need to approach our IT solution to make sure we are social distancing here as we're delivering this information to you, and due to the sheer numbers of people involved on the webinar, we are not able to real-time organize ourselves to respond to your questions flowing. We do specifically look at them afterwards and organize our next informational sessions to be able to respond to that information and also to bring you updated guidance that is emerging. So please keep chatting away during these sessions and send us those questions. If you think of something after, we please encourage you to go to our email right here at healthcare.provider@dhsoha.state.or.us. We are also fielding all the questions from there. Please note we are not able to give individual responses to every question. We do hope you post your questions that we could then generate a response to as part of our future webinars. And please, a reminder, do not send us any personal health information. But again, we will continue these as long as we need to, and we'll keep updating our information real time. And finally, just a reminder, we also provide additional information via the Project ECHO tool that is hosted by the Oregon Health and Science University on Thursdays. Dr. Jennifer Vines with Multnomah County as our health officer and myself have been the hosting faculty, but we have lots of invited content experts or people sitting in for us. So I encourage you to join us on Thursdays through Project ECHO, and you can see the link about the flyer or how to connect to those sessions also from 12 to 1 on every Thursday. I'm going to open up for my colleagues here. Anything we've missed or highlights you want to make sure we add before we close out?
We just got the latest numbers here, a total of 690 cases as of today.
And 18 deaths.
18 deaths.
Great, so that is taking us back to the very first slide. As I mentioned, we had the updated number. We still had yesterday's number on there. So one more time, can you state what those numbers are as of today?
As of today, 690 cases, 18 deaths, and we have tested so far cumulatively a total of 13,826 people for COVID-19 in Oregon.
Great. And for those of you who've been monitoring those numbers, there has been quite an increase in the positive cases captured over the last 4 to 5 days. But that is coinciding with a significant increase in our testing capability. So we just want you to keep that in mind as you're looking at these numbers. Any other comments before we close out? Well, again, we all share our sincere thanks to all of you for doing the extraordinarily hard work on the front line. We are here to support you, provide further information and guidance, and please continue to pass on the message as we around the importance of social distancing to try to keep our surge as low as we can, flattening that curve. And again, thank you and take care. And we will be back Thursday through Project ECHO and the next Tuesday through the same type of webinar with OHA. Thank you, everybody.